My name is Paixao. I'm a cardiologist at the Heart Hospital. These are my disclosures. They're not really applicable to this talk. So we're going to talk about chelation therapy, what we know, what we don't know, and where to go from now. Before we talk about chelation therapy, let's talk about why it may be a good idea to remove some potentially toxic heavy metals from our body. There are at least 7 heavy metals for which there are really strong epidemiologic data suggesting a link between low levels of exposure and the risk for heart attacks and stroke. These are these metals, and for lead and cadmium, there's both a particularly strong link, but also a way to get rid of it. The Agency for Toxic Substances and Disease Registry puts out a list of top offenders. These are substances of interest to which we are not uncommonly exposed to, and for which there's at least moderate evidence for a link between that and adverse outcomes. In this list, there are 4 heavy metals, and among those, lead and cadmium, which we're going to focus on. This is how we get exposed to these potentially toxic metals. For lead, it was present in really high levels in gasoline from the Second World War up until the late 70s, mid-80s. At that time, we were putting out about 600,000 tons a year. Although the levels of lead in gasoline have dropped since, that was all exposed in the atmosphere and deposited in the soil, so we're still exposed to some of that in the soil today. It's also present in paint, depending on where it comes from. A lot of our cities still have lead pipes in the municipal water distribution system. It's not just Flint, Michigan. It's present in cigarettes, even filtered cigarettes, and in batteries, which are not always disposed of appropriately. Cadmium is really present in cigarettes in high levels. It's present in soil, industrial pollution, batteries, but also in our food. Not necessarily unhealthy food, but just food that has been contaminated at low levels through the air and soil. This is some of the information we know about lead and cadmium. Lead has been associated with hypertension, stroke, myocardial infarction, and overall cardiovascular mortality. It's mainly stored in the bone, and once stored in the bone, it stays there for about 30 years. A half-life is 30 years. Cadmium has also been associated with coronary disease, so heart disease, cerebrovascular disease, strokes, and peripheral arterial disease, even after adjusting for cigarette smoking. It's stored in the kidneys, liver, and lungs, to a lesser degree in muscle. It also stays forever in your body, a half-life of about 30 years. For these 2 heavy metals, there's strong, not just epidemiologic data, but also mechanistic data on animal model and human models, supporting a strong link to adverse vascular effects. This is a little diagram to illustrate how we think this may hurt us somehow. So on the left side of the screen, lead is presented to us through those exposures we talked about. It increases oxidative stress. It decreases nitric oxide availability, increases inflammation, activates the renin-angiotensin system. It compromises autonomic function, and also induces epigenetic effects through hypo and hypermethylation. That leads to elevated blood pressure, that leads to decreased kidney function, decreased heart rate variability, and then cardiovascular disease. For cadmium, that's more or less similar. It's also being linked to oxidative stress, a decreased ability of our body to deal with this oxidative stress, and epigenetic modifications that are detrimental. That's been associated with increased blood pressure, decreased renal function through multiple pathways. That's how we think these substances lead to heart disease. So this is the topic of our talk. This is a molecule for EDTA. It's been approved by the FDA to treat lead poisoning. It's actually 2 different substances. One binds more strongly to calcium, the other one more strongly to lead. It's infused through an IV. It goes in usually throughout a few hours, but there are rapid infusion protocols. Once in the bloodstream, it binds to heavy metals, to these cation ions, and it gets excreted through the kidneys. Without this molecule, our kidneys are really not able to excrete these potentially toxic substances. So it's been around for a long time. It was first synthesized in Germany in the 30s. The first report in the literature, in the medical literature, came from the US Navy in the 50s. They successfully used this compound to treat lead poisoning in naval shipyard workers. The first link between, well, the first attempt to treat cardiovascular disease with EDTA came in the 50s. In this study of 20 patients, 19 observed improvement in angina after 20 sessions of EDTA infusion. After that, a couple studies in PAD and angina had more mixed results, so the enthusiasm kind of tapered down a little. And at some point, the American Medical Association actually came out with an advisory recommending against the routine use of this treatment. And since then, a couple randomized trials have come out. They were both negative. And the use of this treatment has mainly been restricted to alternative medicine clinics. And this is sort of how I picture they look like in my mind. I don't know if they all look like the Emirates lounge in Dubai. But it's been discredited by traditional medicine, perhaps unfairly so, but mostly labeled as quackery. And that's how it was looked at by most of us up until very recently. So in 2001, the NIH decided to fund a large, well-powered study to assess whether or not this was helpful to patients with heart disease. And this proposal of using our money, the government money, to fund this kind of research was met with a lot of skepticism by the traditional medical society. And the main reason it was allowed to keep going was that it was designed to show that it doesn't work, then we never have to talk about this again. And this is the study we're going to talk about. It enrolled just over 1,700 patients, mean age of 65, a lot of them with diabetes, mostly men. Most of them had some revascularization done to the heart. They were randomized to 40 infusions of EDTA. It was double-blinded, really the highest tier of scientific evidence you can have on a treatment. Patients were also randomized to high-dose vitamins, although that's not what I'm going to go into. The primary endpoint was major adverse cardiovascular events, which is pretty standard for this kind of study. Patients were followed for a mean period of 55 months, so it's a long-term follow-up study, even for this kind of study. Throughout the length of the study, over 55,000 infusions were administered with very few side effects. And unlike what we had planned for the study, it was positive. It actually showed a statistically significant 18% relative risk reduction in the risk of a subsequent heart attack, stroke, or dying for any one of the two. This was actually still met with some skepticism, but enough to change the recommendation in our guidelines. It used to be a class 3 recommendation, so evidence of harm. It was bumped up to a class 2B recommendation, which translates into may be considered in the appropriate setting. Perhaps even more importantly, there was a strong interaction between diabetes and treatment with EDTA. Among patients with diabetes, there was a 41% relative risk reduction for MI and stroke. That's more than what we see with high-dose statins. Interestingly, if you look at patients with and without diabetes treated with placebo or EDTA, the patients with diabetes treated with EDTA roughly had the same risk of a heart attack than those without diabetes. So it's almost as if treatment with chelation therapy mitigated the adverse effects of diabetes in the cardiovascular system. Still, it was not enough. Most people don't truly believe that this works, and there may be some reason for that. This is how I look at scientific data and how I think scientific data should be critically appraised. This is a Bayesian algorithm for interpretation of studies. So you take into account what you know before the result of the trial, how likely it is that this therapy is helpful. You take into account the results of the study, and then you come up with your post-trial probability or post-test probability. In this case, I would put the likelihood that chelation therapy was beneficial before the first TACT study between the long shot and the toss-up. The TACT-1 study was strongly positive, so I'd say that now there's at least a 50% chance that this truly works, that this truly may be something that our patients may benefit from. How do we find out? We do more research. So after that, we looked at exactly what are we getting rid of with this treatment. And after the infusion of EDTA, we now know that excretion of lead in the urine goes up by almost 4,000%. The excretion of cadmium goes up by about 670%. It also gets rid of other heavy metals, aluminum, cesium, mercury, and nickel. Still not enough, perhaps. So what we're doing, we're running the study again. NIH has approved funding for the TACT-2 study. It's a replicative study, so we're basically going to do the same thing that we did in TACT-1, but this time only in patients with diabetes and a prior heart attack. We are planning to randomize 1,200 patients. And again, double-blind controlled study. We don't know who's getting what, and we're going to follow these patients until we have enough events. The study is ongoing. We have now enrolled just over 150 patients. The Arkansas Heart Hospital is one among the leading enrollers in the country, thanks to some of our research coordinators who are here today. If you have a patient with diabetes and a prior heart attack who you think may be willing to participate in this truly landmark study, please let us know. We will be happy to talk to them and hopefully enroll a few. This may be the next breakthrough in medicine. That's it.